So I'm looking through your bio here. So you're the co-investigator on the Radiant study, which we had the chance to hear a little bit about last year with the virtual meeting in Houston. So I'm really happy to hear additional information from you today. So Dr. Tasser joins us from Baylor College of Medicine and Texas Children's. He recently joined the faculty and completed a year-long clinical science training program at Baylor. His research efforts are focused on better understanding childhood diabetes based on its tremendous heterogeneity. He's particularly interested in the role of genetic factors, micronutrients, and metabolic disturbances in diabetes. His work and dedication, he was awarded the Mike Hogg Foundation grant to study maturity onset diabetes of youth, or MODY, in diverse pediatric populations in Houston. He's had a chance also to publish some of his work in pediatric diabetes. And so he's going to be talking to us today about precision diabetes lesson learned from MODY. So thank you very much for joining us today.
Thank you, Dr. Steelman, and good afternoon, everyone. And today I'm going to spend time on MODY after Dr. Trigestet's great presentation. And thank you so much in the late afternoon sticking around. And one disclosure, and I was planning and hoping to be there in person, but unfortunately with the weather condition, I had to change my plan in the last minute. And I hope this will go well. And here are my disclosures, and photography and screenshots are allowed if you see any useful information. So my objectives today to describe the history of MODY and the current status, and describe commonly encountered MODY forms, and discuss some practical tips for MODY from diagnosis to management, and also discuss an available research opportunity for unresolved atypical cases. Maturity onset diabetes of the young. It's a monogenic form of diabetes characterized by the following features: with autosomal dominant inheritance, early onset of diabetes, usually defined as less than 25 years of age, and no signs of autoimmune process or insulin resistance, and preservation of endogenous insulin secretion, although they have some impaired beta cell function. So during the first International Congress of Endocrinology in 1960s, Dr. Fajans presented mild asymptomatic diabetes occurring in non-obese children, adolescents, and young adults. When he presented his cases, and at that time, Professor Luft and Lundbeck from Europe, and they said, this kind of diabetes did not exist in Europe. They never seen such cases. And Dr. Fajans responded saying that such diabetic subjects did not come to investigator. Investigator had to find them by testing asymptomatic first-degree relatives of known diabetes patients, in which he was referring to a natural history study that he started in 1950s, and he was screening the first-degree relatives of patients with diabetes by regular OGTTs. And 5 years later, during the 5th International Congress of Endocrinology, and Dr. Fajans coined the term maturity onset type diabetes of childhood or of the young as a first time. At that time, there were two types of diabetes. One was juvenile onset type diabetes, which is now we know as type 1 diabetes, characterized by rapid insulin dependence, and are usually seen in children. And then the other type was maturity onset type diabetes, which was seen mainly in middle-aged or elderly people. It can be managed with diet and oral agent alone. And even if they require insulin, that happens many years later. So technically, when he was saying maturity onset type diabetes of childhood, he meant, based on our literature right now, is like type 2 diabetes of childhood. And then in 1974, this is the first paper that used the MODY abbreviation. In this paper, and Dr. Tattersall and Dr. Fajans, they compared the inheritance of classical juvenile onset and maturity onset type diabetes of young people. And then they used these abbreviations at that time as JOT and MODY. And so we are still using MODY, but I guess JOT didn't receive any popularity. In 1990s, and there were the initial genes discoveries happened, and starting from HNF4 alpha gene, GCK gene, and HNF1 alpha gene, the first 3 MODY types. And there's a publication in 1992 in the Lancet from Dr. Hattersley, who is still active in UK and in the MODY diabetes forms. And there was a piece from the article, like they define as the maturity onset diabetes of the young is a subtype of type 2 diabetes that presents from the 2nd decade and has an autosomal dominant mode of inheritance. So at that time, rather than being seen as a separate entity, it was just thought to be like a part of like type 2 diabetes spectrum. And since that time, there have been explosion in molecular genetics, and now there are at least 14 genes identified to cause MODY associated phenotype. And then they were numbered as like from MODY 1 to MODY 14. However, like based on, there will be like new gene discoveries, and these numbers will only increase over time. And now it's recommended not to really use these numbers and just go by the gene name. For example, GCK MODY instead of MODY 2. So I want to briefly mention about the commonly encountered MODY forms. And starting from the prevalence, we see that the 1.1% to 6.5% of pediatric diabetes population has MODY with high degree of geographic variability, depending on the studies, and anywhere from that range. The 3 most common MODY forms, GCK MODY, HNF1 alpha MODY, and HNF4 alpha MODY, they account for over 90% of MODY cases. And it is estimated that 50 to 80% of MODY cases are misdiagnosed as having type 1 diabetes or type 2 diabetes. Let's start with the GCK MODY, and this is the commonest type of MODY in children. And although in some part of Europe and HNF1 alpha MODY can be more common than GCK MODY. And it's characterized by non-progressive mild hyperglycemia from birth and fasting glucose 100 to 145, and usually A1C less than 7.5%. And caused by a pathogenic variant in GCK encoding glucokinase, which leads to slightly higher set point for insulin secretion. That's why they have mild hyperglycemia. Affected parent usually remains undiagnosed or has been misdiagnosed with type 2 diabetes. And it's rarely associated with micro or macrovascular complications of diabetes. And it doesn't require treatment except special circumstances like pregnancy. And during pregnancy, as we know, the hyperglycemia is associated with adverse effects, and like the excess fetal growth, neonatal hyperinsulinism. So if the mother is hyperglycemic because of GCK MODY, if the fetus doesn't have GCK MODY, that slightly elevated blood sugar, it will lead to increased insulin secretion, and then it will lead to fetal overgrowth. However, if if the fetus has also GCK variant, that slightly higher blood sugar level, it will not lead excessive insulin. So then the growth is expected to be normal. The second one is HNF1 alpha MODY, and previously known as MODY 3. This is the most common type of MODY, resulting in familial symptomatic diabetes caused by the heterozygous pathogenic variant in HNF1 alpha. and it presents during adolescence or early adulthood. Initially presents with postprandial hyperglycemia, followed by fasting hyperglycemia. And because HNF1 alpha affect renal tubular reabsorption, and these cases may have postprandial glycosuria even before significant hyperglycemia. And frequency of microvascular complications are similar to that are seen in type 1 and type 2 diabetes, and primarily dependent on their glycemic control. And in terms of treatment, the first thing is diet, obviously, and then this form of MODY they are extremely sensitive to the sulfonylureas, and there is emerging evidence that glucagon-like peptide-1 agonists, they can work well as well. And if these options are exhausted, next step will be insulin. The next one is HNF4 alpha MODY, which is similar to HNF1 alpha MODY, and it causes familial symptomatic diabetes, but much less common than HNF1 alpha. It has similar clinical presentation and treatment responses to HNF1 alpha MODY. In 15% of the cases, and they have a history of neonatal hyperinsulinism followed by diabetes during adolescence. And then the last form that I would like to mention is the HNF1 beta MODY, which is also known as MODY5. And this is also known as renal cysts and diabetes syndrome, caused by heterozygous pathogenic variants or deletion in HNF1 beta gene. The main presentation is the renal cyst or dysplasia first, and then they develop diabetes later on. In this kind of MODY, the patients have insulin deficiency due to pancreatic hypoplasia, and they have some hepatic insulin resistance. And treatment is insulin injections. And interestingly, on this type of MODY, about 1/3 to 2/3 of cases are due to de novo genetic variants or deletions. So we don't expect to see a family history of diabetes in a significant portion of HNF1 beta MODY. So I'd like to point out a few different publications in terms of clinical characteristics of MODY. The first one is from a search study. And in search study, the investigators decided to select patients based on 2 criteria to do MODY genetic testing. And then they selected the subjects based on being negative for diabetes antibodies, and also the fasting C-peptide greater than 0.8. When they put these 2 criteria, they had about 586 subjects. And then when they tested these 586 subjects, 47 of them, they were MODY positive, which was about 8%. And then when they look at these 47 subjects, only 3 of them, like only 6% of them had a clinical diagnosis of MODY previously, and 50% of them treated with insulin, and many of them are unnecessary insulin treatment. And then they compared the characteristics of MODY positives with MODY negatives. And the 3 main things here is, number 1 is the younger age at diagnosis, 11.5 versus 13.3, and lower BMI Z-score, 1.2 to 1.8. And then fasting C-peptide, lower fasting C-peptide, 2.2 to 3.2. And the other thing is that in this comparison, it's interesting that the parental history of diabetes, it wasn't too different between MODY positive versus MODY negative cases. And then about 40% of the MODY positive cases, they had acanthosis nigricans. The other study, it was mentioned just in the previous presentation, Prodigy collaboration. In this one is investigators performed the exome sequencing in over 3,000 participants with previous diagnosis of type 2 diabetes. These are participants from SEARCH and Today study. About 2.8% of this cohort had diagnosis of MODY. And then when they look at the comparison, again, the younger age at diagnosis and lower fasting C-peptide, it was helpful to identify those patients. And I'd like to briefly mention our local study at Texas Children's Hospital. And we also wanted to define patient characteristics in our diverse, racially and ethnically diverse patient population to guide the decision to conduct genetic testing. And we have an electronic health record-based diabetes registry. And at the time of study, we found closer to 5,000 cases who were seen in our clinics within the past 3 years with one of the following clinically assigned diagnoses. We had 1.3% MODY and 78% type 1 diabetes and 20.4% type 2 diabetes. We then screened this registry for likely MODY cases, and we named as study cohort, and for 3 criteria: diagnosis of diabetes less than 25, and we were pretty strict, and we put like family history of diabetes in 3 consecutive generations and absent islet antibodies except GAT65. This led us to like 350 patients, which was 7.4% of the cohort, and 62% female, and mean age was 13, and 57% of them are of Hispanic ethnicity, and mean A1C was 9.8%. So when we look at the, again, previously assigned clinical diagnosis, the frequency of MODY was 3.5 times higher in the study cohort than in the diabetes registry, 4.6% versus 1.3%. Also, like there's a change in this pie graph. In the entire diabetes registry, we had about 70-something% type 1 diabetes. Now we have 78% type 2 diabetes when we put the family history of diabetes criteria especially. And then to further refine the characteristics of patients with the highest rate of MODY, and we performed the clustering analysis, and cluster with the highest rate of prior MODY diagnosis, which was about 25%, they had the lowest age at onset, the lowest BMI Z-score, the lowest C-peptide level, and then lowest acanthosis nigricans frequency. And interestingly, in this cluster, molecular confirmation rate was about 60%, 3 in 5, in those patients who had undergone genetic testing. Obviously, not all of them had genetic testing. And lastly, I'd like to point out this study from Sweden, absence of islet antibodies and modestly raised glucose values at diabetes diagnosis should lead to testing for MODY. This is a Swedish national prospective cohort study, and they had about 4,000 patients, age 1 to 18 years, diagnosed with diabetes between 2005 and 2010. And they had the same aim to identify discriminatory characteristics at diabetes diagnosis for 3 most common MODY forms. So in the entire cohort, and with the research-based and also clinical sequencing, they found 46 MODY cases, which was 1.2% of the entire cohort. And then when they restrict this testing to only autoantibody negative patients, they were still able to capture these 46 individuals, and detection rate was 15%. When they further restricted to autoantibody negative patients with A1C less than 7.5%, they were able to capture 36 of them, and then detection rate was about 50%. And then when they look at the characteristics, the MODY patients all of them, they were negative for islet antibodies, and A1C was lower. C-peptide was higher than entire cohort, and nobody had like DKA, and there's higher rate of parental history of diabetes in the MODY form to entire cohort. I'd like to point out to the, especially the C-peptide, the earlier studies mentioned about the MODY patients, they have lower C-peptide, and in this cohort, they reported MODY patients, they have higher C-peptide. I think it's depending on the population, and this population, the entire cohort characteristics is mainly driven by type 1 diabetes because of very low prevalence of type 2 diabetes in children in Sweden. That's why when they compared it like C-peptide in MODY patients, it was higher than the entire cohort. However, when we look at our US data, especially if a cohort is includes a population with a high prevalence of type 2 diabetes, then the patients with MODY, they have lower C-peptide compared to type 2 diabetes patients. So considering all this, when should we suspect MODY in children? And there's no single clinical criterion. And if a patient has a previous diagnosis of type 1 diabetes, if they are negative for islet antibodies, if they have preserved beta cell function and low insulin need beyond partial remission phase, which was defined as if they still have a detectable C-peptide beyond 3 to 5 years, and that may indicate preserved beta cell function. And then the positive family history, it also needs to alert us in patients with type 1 diabetes. If a patient diagnosed with type 2 diabetes, if they don't have significant obesity, if they don't have acanthosis, however, having an acanthosis doesn't really exclude MODY completely. And also like positive family history, again, a lot of patients with type 2 diabetes, they also have a positive family history of diabetes. And I guess depending on how strong that family history, it would be helpful for us to suspect MODY. The other thing is the characteristics features for GCK and HNF1 beta MODY. So then for GCK, if a patient has non-progressive mild hyperglycemia, or for HNF1 beta, if a patient has renal cyst, renal dysplasia, and then we need to consider these two MODY types. Another helpful tool for us is the using a MODY risk calculator. And this was developed by University of Exeter group in UK in 1 to 35-year-old Caucasians for 3 most common MODY types, and it's available for free on the internet. And they use a few variables to calculate the risk of MODY, including age at diagnosis and gender, and whether they're currently treated insulin or not, when did they start insulin treatment, their BMI, A1C, and whether there's a history of family history of diabetes, like parent affected with diabetes, and their ethnicity, and if they have any other features suggestive of MODY. So although this is helpful, there are some limitations when we use this calculator in our patient cohorts. First of all, the population they developed this model is Caucasians, and so then applicability of this calculator for Hispanics, non-Hispanics, Blacks is currently unknown. The second thing is the model developed for 3 most common MODY types: GCK, HNF1 alpha, and HNF4 alpha. So if you have a patient with another type of MODY, then this calculator may not be helpful. The other thing is that this calculator does not include islet autoantibody and C-peptide status into consideration. And then lastly, they use ambiguous type 1 diabetes definition when they are developing this calculator. And I'd like to share the definition used for the model development. Type 1 diabetes was defined as occurring in patients treated with insulin within 6 months of diagnosis. Otherwise, patients were defined as having type 2 diabetes. So if you think about our patients with MODY, our patients with type 2 diabetes, there will be like a lot of patients who are treated with insulin within 6 months of diagnosis in pediatrics. So now I'd like to present a real case, and just to put everything into perspective. So this is a 13-year-old male, presents with excessive drinking, urination, and some weight loss, and BMI 87th percentile, and he didn't have any acanthosis, and he did not have diabetic ketoacidosis. His A1C 8.4%, glucose in 200s, and the patient was suspected to have type 1 diabetes, and he was started on multiple daily insulin injections. His antibody is negative, and this is his family history. So this is our proband here. The mother diagnosed with type 1 diabetes at the age of 10, and she was treated with insulin since that time. And then maternal uncle diagnosed with type 2 diabetes at the age of 30, and he was treated with pills, and he had a heart attack at the age of 38. And both grandparents, they also had history of diabetes. The maternal grandfather diagnosed with type 1 diabetes at the age of 30s, and he was treated with insulin. And the maternal grandmother diagnosed with type 2 diabetes at the age of 22. So this patient then gets a genetic testing done in Athena Diagnostic 5-gene panel, and which shows a heterozygous disease-causing genetic variant in HNF1 alpha, consistent with MODY 3. So let's look at the family history of diabetes again. So if this patient has HNF1 alpha MODY, then there are probably more than one people here, and they also have MODY, but they were misdiagnosed, like especially the mother here, being diagnosed with type 1 diabetes at the age of 10. Currently, the mother is in process of trying to get her genetic testing done. So 8 months after diagnosis, the patient was on intensive insulin therapy with multiple daily injections, and his total daily insulin dose, it was about 0.7 unit per kilo per day. At the time, we stopped the insulin and then started him on sulfonylurea. And I just saw him last week in my clinic, and his glycemic control on sulfonylurea alone, 15-month post-diagnosis, he's only on 2.5 milligram daily, and his average blood sugar 148, 84% time in range, and hemoglobin A1C 6%. So I'd like to spend some time on MODY gene panels. So when we suspect the gold standard is getting a genetic testing done by next generation sequencing with a MODY gene panel. And there are a lot of panels out there, and I'd like to highlight a few of them that are most commonly used at our center. First of all, the Athena Diagnostic, and I'm sure many of you are already familiar with, and they have 5-gene panel, and it costs about $3,000 to $4,000, and then it includes all the most commonly encountered MODY forms. And then if the patient is eligible for financial assistance, and they can get this test done as low as $100 or $400, depending on their eligibility. This panel, until recently, was the most common panel done at our center, and however, recently we are using the other panels more often than this one. The second one is the University of Chicago panel, and so the Athena Diagnostic has 5-gene, but the University of Chicago panel, it has 15 nuclear genes and 3 mitochondrial genes, and it costs about like $4,000 with the cash pay, and if they don't have insurance, there's some discount for them. But it's a comprehensive panel overall as compared to the earlier one. The other one is the Baylor Genetics Laboratory, and they have MODY panel, and which includes 25 genes. similar turnaround time. It costs about 2,000 to 2,500. And then there's also financial assistance program here, and the patients can get it done as low as less than $100. And lastly, I'd like to highlight the in-vitro monogenic diabetes panel, and which has 28 genes and costs about 3,000 to 6,000. The good thing about this panel is that they have a cash pay option. So if patients' insurance denies MODY testing, or if they don't have insurance, and if they are able to afford, so this panel can be done just for $250. And also, like if they are eligible for financial assistance, it can be done for free as well, depending on their eligibility. So after this information, and here are my approach whenever I need to do a genetic testing. So if a patient has insurance, the University of Chicago panel or Baylor Genetics or Invitae panel, they're pretty comprehensive. If a patient is self-pay, then Invitae panel is a good option to go. And then if a patient is eligible for financial assistance, like Invitae panel, Baylor Genetics, Athena Diagnostic, and they can provide the same panel like with a quite cheap or even for free. So what about if the MODY panel is negative? And then the next step would be like doing a whole exome sequencing or genome sequencing, and which then we may get some answers. And we had a local study, and I'd like to share with you here as well. And we identified 10 probands and who had clinical characteristics suggestive of MODY. And they also already had the commercial gene panel, and they were tested negative. And we performed exome sequencing in probands and their parents. So this is the baseline characteristics: mean age 10 years, and 6 females, 4 males, and 50% of them Hispanic, and 4 non-Hispanic white, 1 Asian, all of them negative islet antibodies. And 90% of them, they had family history of diabetes. In terms of their previously assigned diabetes type, 7 of them, they were diagnosed with type 1 diabetes, 2 of them unknown diabetes type, and 1 of them ketosis-prone diabetes. And then all of them, they had the negative MODY gene panel. So we found that in one of the patients, in 11-year-old male, and we found a de novo variant, and this patient was previously diagnosed with type 1 diabetes at the age of 3. This particular variant has not been previously reported in MODY, but multiple individuals with neonatal diabetes reported to have this particular variant. And then this variant is considered likely pathogenic. In the second patient, in a 17-year-old female, had a frame shift deletion in RFX6 gene. And this patient was previously diagnosed with type 1 diabetes at the age of 12. And this particular variant was inherited from the mother, and who was diagnosed with type 2 diabetes at the age of 25. And there's a report showing that the heterozygous protein truncating variants in RFX6 causing MODY in some individuals. So in our study, we found 2 new MODY cases in children who were previously diagnosed with type 1 diabetes, showing that the clinical utility of exome sequencing in atypical cases of diabetes suspected to have MODY with a 20% molecular confirmation rate. So although this is helpful, but the exome sequencing or genome sequencing is not available for many of us in clinical setting. However, we have a research opportunity Dr. Stillman mentioned earlier about the RADIANT study, in which offer patients whole genome sequencing if they are eligible. And especially if you have a patient that you suspect for MODY, and then if you already done the genetic testing, and then if it comes back negative, and they will be eligible for the study. There are many other atypical diabetes, they can still be eligible, but from the MODY perspective, if they have already negative gene panel, and they can they can get benefit from this study. There are about 15 centers in United States, and just briefly, I want to summarize the process for Radiant, and it accepts application online and from anywhere in the US. If a patient is eligible, they will get whole genome sequencing and even more studies. And the study has multiple stages, and stage 1 and 2, it doesn't require any travel, and the blood work is done in a local Quest laboratory. And if they pass those stages, if they get their whole genome sequencing, and then at the stage 3, they will need to travel to University of Chicago or Baylor College of Medicine. I'd like to put up our contact information here as well. And our site PI is Dr. Balasubramaniam on the adult side, and the pediatric side is Dr. Redondo, who gave a presentation last year at Pestola as well. So in summary, MODY forms are excellent examples of precision medicine in diabetes. And no uniform clinical criteria for MODY exists, and high clinical suspicion is key for diagnosis. And also, like, available research opportunities, they can be leveraged for unresolved atypical cases. So with the advancement of genetic and with the better characterization of diabetes types, I think we have a bright future ahead for our patients with diabetes. Thank you, and I'm happy to take questions.
Thank you very much, Hyde. Very interesting. Thank you. So we'll wait for Q&A or comments from the audience. Are there any questions from our live audience here? I guess from my standpoint, I'm curious, or just to sort of start with questions, I'm curious, what do you see as far as like how, obviously for the typical index of suspicion for maturity onset diabetes youth, you're thinking about a family history. How much do you see that plays into the history? I mean, are there times, is that something that you feel like is a roadblock that people, shouldn't get hung up on, or is it something that's key regardless?
Yeah, I think there are a few points like that. Yeah, that's a great question. Number one, for HNF1 beta MODY, almost half of them, there's no family history. So it's a de novo mutations. Mm-hmm. And also, based on different studies, they reported that about 1 to 7% of de novo cases. So again, they will not have, like, even for other MODY forms, they will not have the family history of diabetes. And then I was gonna say one other thing, it slipped from my mind. So then because of those reasons, like the third thing is the sometimes if it's a milder form of diabetes, although the parents, they may tell they don't have diabetes, but maybe they were never tested, they were never diagnosed. That's the third thing. So then lack of the family history of diabetes, it doesn't really fully exclude, but I think at this time of like the difficulty getting the genetic testing done, probably we should start from the one with the family history of diabetes. I think in my vision, like once the genetic testing gets more cheaper and cheaper and cheaper, and things will be much easier to find. Even like probably we are missing a lot of people because they have overweight, because they have acanthosis, and we just assume they have type 2 diabetes, but maybe they don't have type 2 diabetes.
Is there anything specifically that you do see in cases where type 2 is misdiagnosed in someone who has MODY? Is there anything, like, as a clinician for myself, that I can look at and say, oh, maybe this patient I originally thought had type 2 because he was obese and, had mild hyperglycemia. Maybe this is really MODY. Yeah, I think if there's a mild hyperglycemia, non-progressive, then they will deserve the GCK MODY testing. Especially, like, I think if they have like the very strong family history, especially pre-generation, that makes me quite suspicious. I mentioned our cohort of 350 patients. Only a few of them, they got tested actually, and it would be really great to see like what's the real MODY
percentage in those people. They have all 3-generation family history of diabetes, and I assume it's much more.
It would be nice, I agree, if there was some way, to have like some of the, the sponsored genetic studies, like, for skeletal dysplasia or obesity, to have something that easy to look for the common forms of MODY as well.
Yeah.
We do have a question from the audience. Can you read it, or I'll read it for you if you'd
Yeah,
like?
I can read as well. So, how likely to transition a patient from insulin to oral medication after many years of MDI treatment successfully? Yeah, this is a great question. Like because HNF1 alpha MODY, so that's the best example. They are very responsive to sulfonylureas, but it's also known that after many years they become insulin dependent. There is a with the age, with the other factors, they at some point they will require the insulin. My suspicions, I haven't read anything particular, but if it's many years from diagnosis, they will less likely to just be controlled with sulfonylureas. For example, for the patient that I presented, the mom who has a diagnosis of type 1 diabetes, and probably she's in her 40s or 50s, and even if she's HNF1 alpha MODY, it's unlikely that she will be well controlled just with that medication alone.
Okay. Any questions from the audience at this point? Well, thank you very much for joining us today. Do you have any final thoughts? What do you feel like would be the most important take-home point that you would offer for pediatric endocrinologists as far as thinking about MODY or the logistics for getting them referred to your program?
Okay, so I think that my main home message is that we need to be suspicious for MODY. The other thing is that I think just genetic tests being expensive, it shouldn't prevent us to do genetic testing. There are some options out there. So we need to take advantage for in vitro panel, maybe financial assistance programs. And also as of this time, this really Radiant is a great opportunity for all of us. We can also use that option. And starting from the very, I guess, more obvious ones, and then we can go down along the path. That's my main messages today.